Good morning. How are you?
I'm very well, thank you.
Thank you for joining me.
Thank you. Thank you for inviting me.
Absolutely. I know what your specialty is, but if you can introduce yourself and a little bit of your background to the viewers and let us know what you specialize in and what you see day to day, we can start from
Fantastic.
there.
Lovely, thank you. So based in UK. I'm a dermatology consultant, so I'm Dr. Anita Talwale. I specialized in hair, and I've been doing specialist hair practice for nearly 14 years now. I was the former president of the British Hair and Nail Society. And so my remit clearly is looking after patients who are struggling with hair loss. That's my big part of my practice.
I love that. That's as mine as well. I have a hair replacement clinic. And we were talking briefly before this. So, what do you see on a day-to-day basis that are some common hair loss issues?
So the day-to-day basis is majority of my patients are females, but more latterly I'm getting men as well who've been concerned about thinning. So the biggest people or patients who come to me are patients who are getting thinning of hair, particularly on their central scalp or on the crown, uh, much more so in females after they've hit menopause. So that's my biggest group, people with either hereditary hair thinning or people with postmenopausal symptoms who present, and it's quite distressing for them. I get younger patients with the same problem as well. When things come earlier with conditions like polycystic ovary, the same thinning can occur much earlier in younger patients. Um, the second biggest group I get is with the autoimmune type of hair loss, which is called alopecia areata. And alopecia areata, typically the age group I'm getting is your young adults. So you're between your 20 and 30, but I've got so many teenagers really distressed, isolated patches of hair loss, which then merge. And I have patients who come with then complete hair loss with totalis and universalis. So that's my biggest second group of patients. The third the group is where the hair cycle is a problem. So people are really distressed when hair is shedding. And this is quite distinct from thinning, but the shedding is quite dramatic. Patients are convinced they're going to go bald. That's generally the theory when they just walk in, am I going bald? And so that group of patients who get a hair cycle problem, that's my biggest third group of patients. And again, I go through the reasons for that. But what I do not want people to forget, there's a smaller group of patients who come to me where they are unaware or their referral team is unaware, is they're getting a scarring alopecia. Now, this basically means when they're losing their hair, that hair loss is permanent. And that gets hidden under other types of alopecia. So even if patients have come to me or clients or patients, I'm always taking a step back and saying, okay, is that the true problem they think it is, or is it hiding another problem? So I'm a little bit of a detective to find out which one, but that's my general group of people who are coming to me.
Okay. And do you see any commonalities between the different types of alopecia and the people experiencing those hair losses?
So more than commonality is what people perceive as commonality. Everybody passes on as it's okay, it's aging, nothing can be done, or it's shedding. Some people are genuinely clear, there's a reason. But what I'm trying to emphasize is they are different. It's not commonality. In fact, they can occur together, but they are different. And understanding the difference at the beginning can help patient understand the problem, and I can target treatments. So more than commonality, the commonality is the psychological distress. Any of these. So psychology is the biggest commonality, but not the types of hair loss, which are quite uniquely different.
Right. And what in your opinion, what do you think causes alopecia? Or I'm sure there's a ton of different reasons, and this is and by no means a diagnosis for anything, for anyone, and they have to seek their own medical professional advice. But what could be some causes?
So first of all, alopecia is very loosely used. In my mind, alopecia and hair loss is the same. So when patients are told they've got alopecia, in my mind, there's a specific type of alopecia called alopecia areata. And that's what patients may be alluding to. But hair loss is not considered as alopecia. So there's a slight there's a bit of a confusion in those terminologies. So when you said alopecia, I'll probably go straight into alopecia areata, because that's a unique type of alopecia, which is termed as alopecia areata. And if you look at that particular type, it's more autoimmune. So what happens to us? All our hair is protected by something called as immune privilege. So we are all protected. But for some reason, the immune privilege is lost. And when the immune privilege is lost, the body provides or sends a flurry of inflammatory cells at one area of the hair called the hair bulb. And then what happens is temporarily, because this is a non-scarring type, temporarily you get shedding, but it's shedding in a very localized way. So it starts as bald patches. But in some people, it can be very dramatic and you get diffuse shedding, quickly going on to alopecia totalis. So it's a very unique type of hair loss. But that may not be the case in, say, the hereditary type, where we've talked of thinning, which comes gradually. In there, it's your genes. I usually say, thank you, mom, dad, because that's what they're giving it to you, but they're giving the good and the bad. So thank you. But then taking that history. So that's thinning. And then thinning is completely different pathology to it. What's happening in thinning is there's a process called miniaturization. So our hair follicles, again, have good quality hair when you're a young child, young adult, when each hair follicle is producing good 3 strong hair. What happens with the process of miniaturization is there's shrinkage. And as shrinkage occurs, the hair density and the volume and the thickness of the hair starts shrinking. And eventually you can get single hair units or there's no hair. So when we are looking at that type of hair loss, not quite alopecia hair loss, it's more a process of gradual process. And I say it's like in a cruise control. It's going gradually. Eventually, when the time patients come to me, the thinning has gone too far. So all I can offer them is let's try and do treatments which will prevent worsening. I unfortunately cannot bring back. So I encourage people, if you're noticing thinning, please come sooner because I can do something about it. If you leave it later, all we're trying to do is prevent it worsening. So that's one type. And then the third type, which is much more common, and everybody talks more commonly about it, is the shedding, because it's dramatic. And that shedding is what's talked about, whether health matters, your food matters, your diets matter, postpartum, drugs, illnesses, all of those cause a hair cycle problem. And that's the one which is more common in, say, Google. It's hair shedding.
Right.
But that's just one type of hair. So, and then as we said, scarring, which is completely different. We can touch on that later.
Right. So what's interesting to me is I'm sometimes everyone's last resort, right? When they come to me, they've gone to their dermatologist and their internalist. And from my perspective, a lot of people that I've seen who may be younger, 8 to 12 or 15 years old, they have one thing in common is they go to bed with a wet head of hair. So I've questioned, is it fungal or is it yeast that could turn that light switch on, that maybe they're created an outside infection that is just on the surface of the skin, or is that just a coincidence, do you think?
A coincidence.
Okay.
Wet hair, it will not magic fungi infections. Fungus comes when puberty hits. There is an overload, and it's just a natural phenomenon of after puberty. Young children getting it, there probably is another cause. Just going to bed with wet hair should not be any reason at all to have a deeper problem. And it may cause trauma and breakage probably. And we've got a condition called trichotillomania, when there's breakage much more in younger children. But that's more breakage, and it's after the hair have left the scalp. It's not something which is on the scalp or below, no.
Okay, thank you for that clarification, because I've looked at that and wondered multiple times. So that's fascinating. And then over here, like you said, alopecia is used so loosely. And for women in general, there has been a lack of diagnosis. It's very unknown. But recently, I've seen a lot of women being diagnosed with androgenic alopecia. And can you just clarify, what is that?
So the term androgenetic alopecia is used again very loosely. Androgenetic is when androgen excess causing alopecia, but it's not that clear. In women, it's much more complex than that. So it's better to change the terminology to pattern hair loss. It's in a specific pattern. And yes, it can be a female pattern, a male pattern, but a male can have a female pattern, a female can have a male pattern. So it's better to term it as a pattern, which is why we're moving away from the term androgenetic, which very quickly hones in on androgens and the hormones, because there are other reasons. So that's the first thing. And then, so if you're looking at pattern hair loss, what the process happening in pattern hair loss is, as I alluded to before, it's the process of miniaturization. But the miniaturization occurs in specific sites. So very commonly, if it's classic female pattern, and I use, because I worked with Professor Rodney Sinclair in Australia, I use his scale. So I say Sinclair pattern. It's classically thinning. And commonly people are saying, oh, my scalp is showing. Or more often, I went in a lift and looked at the mirror and, oh my God, I can see my scalp. That's the pattern you see classically in females. Also, the crown is thinner. So that pattern has got some link with hormones. So it's got a little bit of androgen, but it's got other reasons. And which is why the treatment for female pattern hair loss is much more varied than for male pattern, which is a bit more linked maybe to their testosterone levels. And so their pattern is different. And I usually refer to it as the Hamilton-Norwood scale or their pattern. And they have more typical, they have got more clear, because what you will see as the male pattern evolves, it starts with the frontotemporal scalp, gradually the frontal scalp, the crown. But what you'll see very often, they've always got a band. Men always have the last bit remaining because their hormones are protected there. So this is why theirs is much more clear androgenetic as opposed to females. So it's better to move away from the terminology. It's a pattern loss in a specific distribution, maybe androgenetic, but there may be other reasons.
Well, and that brings me to my next point, because they're starting to pair that with scarring androgenic alopecia, which is what you were referring to as well. And from my experience, just seeing some of the women that come in, it's a band that they're losing around the hair and it's working its way back.
Yeah. So that what you're describing is called one type of scarring alopecia. It's called frontal fibrosing alopecia. Now, again, it's become an epidemic. Just in my clinic, it's a flurry. So when I talk of scarring alopecia and we look at the commonest types in there, frontal fibrosing alopecia, it's top there, followed by another one called lichen planopilaris. So those two are topping the scarring chart in a way. So what's happening in frontal fibrosing alopecia, and again, there's a common theme happening here. It's very, very common in women, though I've got men, I've got father-son, I've got mother-daughter, but the commonest people I get are women, perimenopausal, menopausal women. And what's happening for them is it's like a band. I used to say it's like an Alice band of hair loss starting from the frontal scalp. But now we know it's not just frontal. Unfortunately, it can go behind the ears and even in the posterior scalp. So for them, what is happening is when we talked about immune privilege for alopecia areata, it's the same immune privilege, but this time in this group of patients, it's targeting the stem cells. It's called the bulge of the hair follicle. This is where the stem cells resides. If anything targets the stem cells, the damage can be permanent because they are the growing bit of the hair, which is why when patients with scarring alopecia present to you, and one type, as we said, is frontal fibrosing, you'll probably find they get like a very smooth white appearance. I say it's like a baby's bottom. It's so smooth because the hair follicles have just gone. That has lost its hair permanently. The follicle has sealed. There is no chance, unfortunately, of that hair recovering. So this group of patients, early detection, early intervention may help. And I say may because it doesn't always help, but I've got lots of treatments in my armory to try. But the group of scarring alopecia, so that's one type. The other also a very common type is the same pathology, the same type of inflammatory cells, but you get it in the scalp. This is when it gets mixed up with other types, when you get pockets of hair loss, which patients and clients will style it for a long time, but they will show other signs. So there will be signs, they will be saying, my scalp is really itchy, it's burning, it's getting exposed to multiple areas. I'm getting the sun, and actually it's shedding in multiple areas, and then my hair is not coming back. This is not eczema. This is not psoriasis. This is not seborrheic eczema. Look at it, because it could be that under that scalp scaling, the hair follicles are getting inflamed, and those hair follicles are getting lost. So this type of scarring alopecia very often gets misdiagnosed. At least a frontal fibrosing alopecia is visual. You know it's different, though it gets misdiagnosed as male pattern thinning or female pattern thinning. But this one gets missed more because it gets mixed up because of the scaling as eczema or psoriasis. And treatments are done for so long to remove the scales much more, but not look at the basic pathology. So by then, when they've come to me, unfortunately, they've lost that hair permanently. I can do nothing. I can again prevent the next lot. So scarring alopecia mimics, gets disguised as common patterns problems, scalp problems, and if left untouched, they are permanent. So those are the worrying which I want to say they are not that clear in the start, but picked early, like anything, we can hope to prevent that hair going permanently.
And you mentioned that there could be some possible treatments for those situations. What would be an example of some of those things that you could do?
So this is again then this becomes medical because it's prescriptions. So when you talk of prescriptions, it's a conversation. You have to have a conversation. That's my big conversation because treatments have side effects. And you have to have the patients understand their journey, and I need to support them, but I need to give them, every treatment can have some issues. But again, it's a balance. We're controlling your hair, so if I want to look at it, the commonest starting treatments are usually, if it's diffuse, then you're looking at steroid shampoos. If it's localized, you're looking at injections of steroids.
Excuse me.
Either in case of alopecia areata, which is localized patches which are non-scarring, or the scarring alopecia, where you can target at a specific area under the skin where we know the stem cells are. We target with anti-inflammatory. Remember, we said it's inflammation causing the stem cells. So if you inject steroids, targeting the areas where we think the inflammation is, which we will know because we've got dermoscopies and trichoscopes to identify. So that's the next. So local treatments, injectable treatments, and then very quickly, we want to work inside out because there's only so much you can target locally. So if you're looking at scarring alopecia, depending on the types, you've got anti-inflammatory tablets, and there's a whole group of them. There's one group called the hydroxychloroquine. There's another group called tetracyclines. There's doxycycline. You again move further. There are retinoids. There's isotretinoin, acetretin. So they're again drugs or immune suppressants. So you can go the medical route if patients can tolerate it, and obviously depending on side effects, but there are treatments. And that's what, again, people don't know. People think there is nothing I can do. Actually, we can. We can stop the process if we can. But of course, you have to know the side effects. If we go end of the road, then you need to know when to stop as well. And we need to then, I always say it's both. Patients have to have the confidence of cover-ups, disguising it, using wigs, using fibers or micropigment. All of those matter in the same breath as treatment. So they should run parallel. One should be over the other. And I feel very strongly, patients should leave your clinic having had the medical bit done, but also the confidence to face everybody else. So it's both, but they are not the main thing. Unfortunately, that becomes the main focus. It then hides something which can be addressed medically. And I feel it's a joint work. It should be done for every patient.
I agree. So is there anything that you could recommend or do recommend in the way of diet to try and avoid inflammation on the inside?
I wish I could. It's not as easy. We do not have anything which we take which magically gets inflammation down. Remember, your body is not inflamed. You are a fine, fit, healthy person. It's just the local inflammation which the body is targeting. It's not a systemic. You're not unwell. You're not going to catch any infections. Your inflammation is down. It's just a local. So there's nothing, you can eat well, but that's not directly linked to the inflammation because it's targeted locally.
Oh, fascinating. And I've read that your hair is one of your biggest organs on your body. Is that correct?
Your skin is, and the hair obviously goes part and parcel with, yes.
So be gentle and kind.
Yes, absolutely. Absolutely.
Is there anything that you think that maybe we didn't touch on that would be helpful to add?
The psychological thing. I think it's so vital that we shouldn't forget, because there is so much I get, oh, it's only hair. Not really. It's more than that. it matters. Patients, there are so, again, I keep saying patients because I'm a medical doctor, they are not away from social contact. They are isolated. They don't show their partners their problems. They're struggling. Young children with alopecia areata, adults, all of them are going through phases. They have got hopes dashed. They have not been taken seriously. Oh, it's only hair. Oh, it's part of normal aging. And those kind of things. And I well up literally just when I'm starting to talk to patients, because you need to listen, give time. Don't give patients medications till they have actually, or don't just give them false hopes, both, because you need to understand where they are coming from and help them through their journey. And so I feel psychology is the biggest thing we have to do. And that's for any type of hair loss. Doesn't matter for men, young adults, everybody. It is very. And so if I was going to take one common message, please look after your patients, look after the psychological impact. And of course, don't ignore the medical side.
Yeah, I agree. When I see some clients that come in, they will tell me that they've spent 2 hours in the morning just getting ready to place hair. And it's a much more larger topic than what it's given credit. But I appreciate your time and spending this morning with me, and I value all your knowledge. And is there any way that if somebody is local to you or virtual, that they can contact you for treatment or consultation?
The locally, absolutely, I'm available. Virtually, it's just very hard because, as I said, it's so difficult because hair is not something you can give an advice on it, because you need to touch, feel, look at it, part it, look at things you don't know are there. I then very often in my clinics, I'm taking photographs, taking dermoscopic or trichoscopic images to show patients. And it's very often patients have come with a different idea. And only when I examine them fully in a very systematic way, looking at their shedding cycle, looking at the miniaturization, which I just find are difficult to do it virtually. And so I know I struggle. But on the positive, I'm standardizing photography nationally, and I'm very involved in that at the minute. So over time, if we give good quality nationalized, standardized images, then they will supplement potentially a future virtual consultation. But for now, it's more touch, feel, see, look, examine, talk. It's much more difficult to do virtual with hair. So yes, so
Yeah, I understand that.
yeah.
Well, again, thank you so much for your time, and I appreciate all your knowledge and what you do, because it's appreciated.
Thank you so much for inviting me, and I hope I've been some help to your group of people.
Absolutely. Hopefully we can do this again.
Thank you so much.
Thank you. Have a good day.
Thank you. Bye-bye.
Bye.
Bye.